These are not my words. So a mild hirsutism without anything else, you don't even need a testosterone. You may do a testosterone. I'm not saying you don't do it, but basically it may not be required. Androgen testing, however, is warranted in women with moderate to severe hirsutism and in women with any degree and associated with rapid onset and fast progression. So if a woman of 30 complains that I have started developing hair now, not in the peripubertal age group, or a menopausal age woman starts doing that, she certainly requires evaluation. A young girl who says I have a couple of hair here and a couple of acne there, you will not find anything. You may do tests, but you will not find anything. The best test would be an early morning plasma testosterone level. That's it. I mean, nothing else is required. If the plasma total testosterone is normal in the presence of risk factors of hyperandrogenism, really speaking, if at all you want to do another check, it would be plasma free testosterone. As I said, with high likelihood of CH, you could do 17-OHP and DHES. And very rarely are intermediates like androstenedione and DHT, etc. measured. So I'm going to close here. So basically, in a nutshell, what I wanted to say was that PCOS is a very myriad kind of syndrome with a lot of implications apart from the menstrual irregularity that we are familiar with. So always insist, if you know the patient well, to get glucose testing, lipid testing, liver testing done. And as far as the hirsutism is concerned, I have made my point clear on what androgen testing is generally followed. Thank you so much. Okay. Okay, you want them. All right. So this is what you were referring to, right? Yeah. Okay, so the hypothesis of insulin goes like this, that persons having obesity will have insulin resistance, and in PCOS and obesity there is insulin resistance, so there is compensatory hyperinsulinemia. Now the idea is that when there is insulin resistance, insulin will be produced in excess. Now why does this insulin then cause effect? Because you say that the patient is insulin resistant, so it should not cause an effect anywhere. So the insulin resistance is actually variable in different tissues. So the adipose tissue, muscle, liver may be insulin resistant, but other tissues like the ovary may not be insulin resistant. So the brunt is borne by the ovary. In the liver, this hyperinsulinemia will typically cause reduction in sex hormone binding globulin, because of which the androgen activity actually goes up, because your free hormone levels are going to go up. In the ovary, it causes ovarian thecal cell hyperplasia through its actions which look like LH and through the IGF-1 receptor, which is a proliferative hormone. So on one hand you have reduction in androgen binding, and on the other hand you have increase in androgen production, both of which will cause an increased amount of androgen driving further LH, and further LH will cause further anovulation. So that's one theory of insulin. As far as the LH FSH hypothesis is concerned, what is said is that there is a hypothalamic firing mechanism which stimulates FSH and LH on a minute to minute basis. In PCOS, this frequency of firing actually changes, and you have less of FSH and slightly more of LH coming from the pituitary. When you have reduced FSH level, reduced means relatively reduced, you have less of follicular maturation, and because of LH you have more of stromal and thecal cell proliferation, thereby resulting in a scenario where the follicles don't mature and rupture, but the thecal cells produce androgen. So you have anovulation plus androgen production. Now these androgens in the periphery are, in the presence of obesity, are aromatized to form estrogens and estrogen, and this estrogen actually occurs in a non-cyclical fashion, it's continuous. Therefore this estrogen will further reduce FSH secretion, because it's a negative loop. Estrogen will reduce FSH. So you start with low FSH, because of low FSH there is reduced follicle maturation, there is increased androgen because of increased LH. This androgen gets converted because there is increased aromatase activity also in PCOS. So more formation of estrogen, more formation of testosterone. More estrogen further causes less FSH, and more androgen causes further increase in LH by a positive feedback mechanism, because non-cyclical feedback causes different things than cyclical feedback. So this is the theory in a nutshell. I mean, I think I'm jumping too much, but that's what is said about the hypothalamic theory of FSH-LH, and the second was the insulin theory. Thank you. Thank you for allowing me to confuse you further more than what I had earlier.